Retinawesome Coach, a program created by Retinawesome Retina in Vitros International to discuss very interesting cases in both anterior and posterior segment from intraocular surgeries around the world. You are very welcome. This is an anterior segment case performed by resident Amanda Marques from the Eye Bank Foundation of Goiás in the city of Goiânia, Brazil, with the guidance of renowned anterior segment surgeon Dr. Francisco W. Rodrigues from Goiânia, Brazil. Also watch our posterior segment series. There are very interesting cases. The patient is a 55 years old woman, best corrected visual acuity 20/100 Snellen. 0.69 logmar. The cataract was cortical and nuclear, involving around 50% of the lens. The retina was pretty normal. So the surgery was virtually divided into 5 steps. Good or bad, we'll know. Sometimes we cannot go pretty fast and sometimes be slow enough as not to implicate unwanted factors into the surgery. So what went wrong? In this case, everything seemed to be pretty cool, and let's take a look at the surgery. The anterior segment part is starting now with the incision and with the capsule rhexis, and very well made and round rhexis. And the technique was a pretty good one after hydrodissection. Phaco started. The technique was a stop and shop. As you see here, the lens is not that hard, and the nucleus is coming very easily towards the phaco tip. Very good control with the pedal and infusion, aspiration, all other parameters. And as you see here now with the simple cannula to attempt to remove some peripheral cortex, and everything seems to be very well made, and now some IA and some more aspiration, then the visco being put in the anterior chamber to make it stable and to prepare the bag for receiving the intraocular lens. Now is the next step of the procedure. The intraocular lens is being prepared pretty well. As you see here, the intraocular lens will be inserted, and very interesting in this case, the intraocular lens was injected, and you see here the lens is not that stable. Actually, it's falling towards the posterior pole, and Amanda was trying to rotate it, but anyways, it fell downhill. Like you see here, you cannot see much of the intraocular lens. So what to do? Now she tried to grab the intraocular lens like that, but it did not go up, and of course she wouldn't have done that if the lens was already in the posterior pole, and the second attempt to lift it up was not possible. And you see here Dr. Francisco, through the pars plana with a 30 gauge needle, is lifting up the intraocular lens. This is a very interesting maneuver because he's lifting up the intraocular lens, trying to equilibrate the intraocular lens that way, right in the middle, and he's pushing the intraocular lens towards the angle, the iridocorneal angle, like that, very slowly. And the first part of the intraocular lens to go is, of course, the haptic, and the haptics have to go very, very gently and superiorly on the top of the iris. Otherwise, the intraocular lens would fall back again, and we'll have here the second instrument, the chopper, helping the 30 gauge needle do that maneuver, and actually pushing everything up towards the iris. And as you see here, the lens, intraocular lens is pretty stable over there. It's not going to go down anymore because it's not on the anterior capsule. That is the next step of the procedure, the attempt to make it by moving it very gently to pull, of course, to push it down on the top of the anterior capsule very slowly, and we have to make sure it won't fall back again. And of course, we have to avoid those defects. And you see here that the posterior capsule is ruptured. That happened during the procedure. It was a small, tiny, little rupture, but of course it enlarged by the time the intraocular lens was being inserted. And now, very interestingly, it's being put the haptic on the anterior capsule, falling down from the iris. As you see here, the maneuver, a very gentle one, and the rotating. It went right there on the anterior capsule, so the lens is being rotated like that, very gently. And you see here in that superior part of the anterior chamber, there is some vitreous over there, of course, and the vitreous is very clear, it's very liquid, it's not hazy, so it's easy to cut like that. It was not necessary in this case to do the anterior vitrectomy with Marques or like 1,800 and pretty more cuts like that. And the maneuver now to remove the remnants of vitreous at the angle, as you see here, is with the second instrument. As you see, this maneuver from outside in, so vitreous remnants and strands are being moved from the together with the movement of the intraocular lens from the very peripheral or the angle towards the pupil. So vitreous will ultimately fall back again, back to where they should be, the posterior pole. And continuing that maneuver, as you see here with the second instrument, this maneuver is made removing all vitreous strands like that with the scissor, and also besides the strands are being cut like that, the chopper helps in moving the vitreous, actually moving the vitreous from the angle towards the pupil. So the intraocular lens looks pretty stable right now, and it's pretty good. This technique now is made on the top of in the middle of the intraocular lens, and to make it more stable. And another attempt to prove it's really safe, and the lens is in the right place, the anterior capsule, and stable. The an air bubble is put inside the eye. So the air is a very good tool as to separate the anterior chamber from the posterior chamber, and any vitreous that could have remained in the anterior chamber will just fall back with the pressure and surface tension from the air bubble, which are of course 3 or 4 now, but they are coalescing into 1 or 2. In this case, 2 bubbles remained in the anterior chamber, and it was necessary to put some stitches over there in the anterior chamber, and that went pretty well. As you see here, the intraocular lens was pretty stable. 2 bubbles remained in the anterior chamber, and the work was done, and the intraocular lens is pretty stable at the end of the procedure. So that was an amazing case that went pretty well, and well managed by Dr. Amanda and Dr. Francisco. very interesting case. We go now to analytics. Let's see the surgery into more detail. As you see here, the phaco was performed, and at the time of intraocular lens insertion, you see this defect at the posterior capsule, and the intraocular lens was inserted, and it was just falling down. It was not possible to recover it. As you see here, the patient looks phakic, and the intraocular lens is there, but out of place. And so this was how it went down, and it got, tilted like that. And even though the second instrument attempted to remove it, to lift it, and also the forceps was used to move it up, and of course it was not possible to lift it up pretty much the same way as we explained. And down here the lens got unstable, but with this maneuver, with the needle, 30 gauge needle, the intraocular lens was lifted up again into the anterior chamber, and the haptics were put right over the iris, as you see here. So it got pretty stable, and had to be rotated very gently. Of course, vitrectomy, anterior vitrectomy had to be performed, and that was about it. Yeah, very good case, and the intraocular lens got pretty stable. Patient got this 20/40 vision, and great result. Thanks a lot, and send us your case.